Good morning, everyone. So here's my plug for the AAP. Our budget really got impacted this year. With membership, there was an invoice issue from National also, but for any of you who are members of National but not members of the chapter, I would highly encourage you to send in your dues because we really do need them. So I'm here to talk this morning about how my practice as part of the Early Developmental Screening Initiative, or EDSI program, which was funded by First 5 LA, adopted developmental screening in our office. I'm from that behemoth county to the south, so most of my data comes from LA County. But as our previous speaker was saying, lots and lots and lots of kids go unscreened, and we need to do a better job of getting kids ready for kindergarten entry. This is national data from 2007, and the only reason North Carolina is circled in green and doing so well is because one of the presenters for the EDSI program, Dr. Marion Earls, is in North Carolina. They have done a really excellent job of promoting developmental screening and spreading developmental screening, teaching how to do it to their pediatricians in the state of North Carolina. As you can see, they're doing much, much better than California. And another way of looking at that is looking at reading to young children. And again, other states are doing much better than California as far as early literacy. In LA County, over the last several years, mostly because of this big grant from First 5 LA, the EDSI project was begun. There was an initial pilot program in 2007. There was an LA County specific collaborative in 2008, 2009, and in 2010, we actually co-sponsored it with Chapter 4, which is Orange County, and had 25 or 30 practices spread through 5 counties in Southern California who were all part of the 2010 collaborative. This is data from the first pilot collaborative, which just shows that learning how to make change and developing the right systems that you can put developmental screening into your practice. So in order to make this happen, you really need to think about systems change. And these are the big systems that we were working on with the EDSI project. Engaging parents, respecting them as the experts about their children that they are. Helping all of us focus on promoting the healthy development of children. Big one is enhancing the bidirectional communication, not the one-directional communication, but the bidirectional communication between parents, providers, and community resources. Systems that lead to better policies for children, and most importantly, systems that lead to better outcomes for children. So hence the EDSI project, Early Developmental Screening Initiative and Implementation is what that all stands for. Big collaborative project, mission to really focus on implementing developmental screening in children less than 5 years of age, working with teams, working in primary care practices. And also teaching the QI techniques that we all need to make change and to learn from our colleagues. Teams were specifically focusing on implementing systems that would lead to reliable change, engaging parents, and using community resources. And the big goals, obviously, to focus on improved development. This is what they call their key driver diagram. Obviously, the big orange box at the top is the ultimate outcome. But what we primarily focused on were the boxes on the right side, the specific things in the practices that we were going to do. Having a practice-wide guideline or a clinic-wide guideline that everyone was going to follow, that everyone bought into, from your front desk staff to the janitor to the practitioner. Embedding those guidelines in your clinical tools, whether it's in your chart or in your electronic medical record. Making sure that staff not only prompts the clinician, but also isn't thwarted in their prompting of the physician. Stratifying patients based on risk, much as Dr. Condell is talking about, looking at those risk factors and using them. And you'll see in both the two top boxes, monitoring this. So looking at what you're doing, making sure that you're doing what you say you are doing. Using structured tools. Prioritizing your information based on both what you're finding and what the parental concern is. Making sure that there's access to parental education materials. Promoting an early literacy program. Again, monitoring that you're doing what you're saying you're doing. And then really developing contacts in your community, using your local resources, and following up, tracking your referrals. Huge, huge project. Obviously, trying to get to the goals that were set for the project in the blue box on the left-hand side. So a little bit about how we did this in my office. In 2008, I was the physician manager for the La Cañada office, part of the Huntington Medical Foundation, which is based out of Pasadena. We were 7 pediatricians, about 4.5 FTEs. We have 3 pediatric locations in the Huntington Medical Foundation, one in Arcadia and one in Pasadena, along with our office. The 7 of us in the La Cañada office really work as a group. It's not 7 people who happen to share space. The patients belong to the La Cañada office, not to me or to Dr. Smith or to Dr. Anderson. So consensus about how we do things was really important. So it was very important to me to get buy-in from everybody to make this happen. We happen to service a middle to upper middle class clientele, fairly well educated, bringing in their sheafs of web information. And we have been using electronic medical records since 2004. Before we got involved with the Etsy project, we did not have a practice structure, especially with our new relatively new EMR at that point. It just didn't promote a routine pattern of developmental screening. We were doing no screening for maternal depression, which is also one of the newer AAP guidelines. And we didn't really have tools to easily track or document screenings or results. What is interesting is that before we went on our electronic medical record, we actually had a very good system in place. But the electronic medical record did not allow us to continue that, and it was actually quite frustrating. So we did a lot of work with our EMR to make it functional. We joined the 2008-2009 collaborative in October of 2008. We had to have a team, so I was on the team, Dr. Neville Anderson, who at the time was our newest and youngest member. We had a medical assistant, and we had an IT person to help us with this. And what we found is that there was no way to record what we were doing in our EMR. So we got Debbie to work with us and put a whole bunch of things into our electronic medical record to make it easier to track.